Okay, we're back. So we will pick up with discussion of diuretic therapy. So you can use diuretic therapy, especially the first two medications. Sometimes they are used for other things, including hypertension, as Ryan was alluding to before we went on break. But they also are a key part to the treatment of heart failure. And what we're trying to do is decrease volume or decrease preload. P for P, we're trying to pull extra fluid off if we can. So there are three main groups of diuretics. The thiazide diuretics, which is hydrochlorothiazide. Chlorothiazide is another one that you could see, but what you'll see on the study guide in our exam is hydrochlorothiazide. Loop diuretics, which is furosemide. Again, there's more than one loop diuretic, but furosemide is the one that you're going to see on our exam, and potassium sparing, which is spironolactone. So one of the big differences is where they work. They're all going to affect how water is manipulated in the nephron. So hydrochlorothiazide works at the first part of the nephron, which is sometimes called the proximal convoluted tubule. The loop diuretics work here in the loop of Henry, and that is where most water conservation or water excretion takes place. So those are the strongest diuretics. And then spironolactone works here in what's called the distal convoluted tubule. So that's the main difference, is where they work and how that will help determine how they manipulate water excretion. So hydrochlorothiazide can be given by mouth or by IV. It can be one of the first line medications for hypertension, and it can also be used for congestive heart failure. A lot of times it's used as a combination with another antihypertensive to help the antihypertensive work better. We talked about one antihypertensive medication in particular that when paired with hydrochlorothiazide or a diuretic, we can decrease the dose of that antihypertensive drug. Does anyone remember which drug I'm talking about? Dun, dun, dun. Okay, so this is my warning to you that in order to feel or to be fully prepared for this exam, these Ryan, come on, impress me. These things have to be really there for you, like you can answer it really quickly. The medication is losartan. We talked about how losartan is very susceptible to fluid status. So that's why you have to be careful. You can't take losartan if you're dehydrated, but it is very good in combination with a diuretic. So if I can take a medication and I can lower the dose of one of the medications when I take them together. So for instance, if I take a combination pill that has losartan and hydrochlorothiazide in it, now I can decrease the dose of losartan because it's going to work better. What kind of drug relationship does hydrochlorothiazide have with losartan? Correct, it's synergistic. That's correct, because then we know if I can lower the dose of one of them, then I know that it is synergistic. It's helping one of the medications work better. If losartan isn't decreased, it's actually kind of dangerous for the patient because it will still be synergistic. So that means the patient might experience a decrease in blood pressure below what we want it to be because it'll still be synergistic no matter what. Oh, okay, interesting. So they could manipulate that medication by increasing the hydrochlorothiazide in order to get the losartan to work better. It could be that they wanted to keep the patient on one drug if it was a combo drug, so they picked that to make the losartan work better. So it's hard to know exactly what they were thinking, but that's still a synergistic relationship. So the biggest issue, how hydrochlorothiazide works, is in the proximal convoluted tubule, you're supposed to get rid, one of the things that happens is you're supposed to get rid of sodium and potassium and fluid. So if I change how the nephron uses sodium, potassium, and fluid, I can, instead of keeping those substances, I can get rid of them and put them in the filtrate or put them in the nephron. So people who are on hydrochlorothiazide, we're trying to get rid of fluid. So the effects could be a decrease in potassium, a decrease in sodium, and dehydration. So this would be an example of a range of effects. So somebody, I want them to get rid of extra fluid, which will help bring the blood pressure down, or help a blood pressure medication work better, or be a very gentle treatment for congestive heart failure. However, I could do it too much, so they could have a little bit of dehydration and a slight change in sodium potassium levels, which is a potential side effect. But if the patient is profoundly dehydrated or their potassium and sodium are very low, that could lead to more adverse effects. So it has the potential to be either. But hydrochlorothiazide can decrease potassium, can decrease sodium, and it can increase blood sugar potentially and increase uric acid potentially, which is hyperuricemia. If someone had an elevated uric acid, what kind of symptoms might they describe? You can talk too. Right. So Scott says joint discomfort. And so what that means, if someone has an increase in uric acid, it's possible that they'll have symptoms of gout. Because increased uric acid, they could have some of those crystals deposit in their joints. Or they could get a kidney stone, but it's the gout kind of symptoms that you might see on an exam. It can have some medication interactions, could decrease effectiveness of anticoagulants and diabetic medications. There's an increased risk of renal toxicity if it's taken with NSAIDs like ibuprofen. So in general, hydrochlorothiazide and ibuprofen are not used together, and this medication cannot be used in pregnancy. So our mainstay diuretic therapy for congestive heart failure is furosemide. You certainly could use furosemide for other things. You could use it for high blood pressure because blood pressure is determined by the resistance of the vessel and fluid volume. It is sometimes used as a treatment for people with liver disease. It can be used for people as treatment for kidney disease because it actually does help kidney function. It increases blood flow to the kidney. So in earlier stage kidney disease, furosemide is helpful. Later stage, not so much. But this is our mainstay therapy for congestive heart failure. The brand name is Lasix, and this is helpful. This is one of the brand name that's kind of helpful to help remember something about this medication. And I got this medicine because furosemide lasts 6 hours. So I would know that the patient who takes furosemide will, for the next 6 hours, will have an increase in urinary output. So I certainly do not want to give this patient a medication that does that right before bed because I know that I will mess up their sleep. So it's important to consider that if someone is on furosemide twice a day, that they not take the second dose after 4 o'clock if they're on like a regular sleep schedule because they will be up all night urinating. It works similar to hydrochlorothiazide, but in a different portion of the nephron. And so the potential electrolyte imbalances are the same, but are likely to be more profound than they would be for hydrochlorothiazide. So the person could be dehydrated, they could have a low potassium and low sodium, they could have a high blood sugar and high uric acid, similar to hydrochlorothiazide. They could develop orthostatic hypotension. Some extra things is they can get ototoxicity, and what that means is that their hearing can become impaired. This could be transient, meaning it only lasts for a little while, or it could be permanent. It can be transient, especially if Lasix or furosemide is given IV and it's infused too fast. Lasix has to be given slowly IV. It's usually 20 milligrams over 1 to 2 minutes. So sometimes if you get 40 milligrams or 80 milligrams, obviously that's going to last a little bit longer when you're trying to infuse it. So if you give it too fast, the person can sometimes have short-lived but feeling of decreased hearing. Other issues, there can be a cross allergy with sulfa. It's chemically similar to sulfa antibiotics, so it's possible that the patient who has a severe allergy to sulfa antibiotics could also be allergic to furosemide, or they could just be allergic to furosemide in general. If the patient has liver disease, you do have to be careful with giving furosemide because the liver is what helps metabolize the medication. So you just have to be careful. If the patient has absent kidney function, so anuria means the patient no longer makes urine, you usually can't give furosemide anymore. But when they have a slightly decreased kidney function or they're just in the beginning of kidney disease, furosemide is helpful because it increases blood flow to the kidney. So when we talked about hydrochlorothiazide, NSAIDs or ibuprofen could increase the risk of kidney problems if taken together. But if NSAIDs like ibuprofen are taken with furosemide, it's not necessarily an increase in kidney problems that occur. It's that the furosemide won't work as well. And so considering the mechanism of action of ibuprofen, why does that make sense? How does ibuprofen work? Hello out there. Ibuprofen should be rolling out off your tongue. That was from the last exam. It's a COX inhibitor, correct. So it inhibits the actions of COX-1 and COX-2. COX-2 are those pro-inflammatory prostaglandins that are created, which increase pain, fever, and swelling. What is the role of the prostaglandins created by COX-1? Right, and that is the reason. So the prostaglandins that are created by the COX-1 pathway are meant to protect the body during stress. It protects the stomach by decreasing production of stomach acid, and it protects the kidney, as Scott noted, because it increases blood flow to the kidney. So if I'm on ibuprofen and it's going to block both COX-1 and COX-2, it's possible that I'll have decreased blood flow to the kidney. And the whole reason that furosemide works is because it increases blood flow to the kidney. And so that's why they shouldn't be taken together. So it's possible that, you are not feeling it today because it's Monday, or it's possible that you're only half listening and thinking that you can watch the recording later. And so you didn't realize I was asking a question. But if you realize I was asking a question and had no idea how to answer the question, then that means you're not studying enough, because these were medications that we had last exam. So these ones should be kind of in your mind. So that is a reason to be sure. It's a way to gauge how well you're studying. you may need to spend more time on it. I'm just hoping that you guys are tired and not tuned out because you know you can watch the recording later, because then maybe I won't do the recordings anymore. I want to be sure that you're with me. It's hard for me to tell because I can't see you. I know I'm Emily, wake up! I know everyone's tired, but I gotta stay with me. Okay, good. I'm only hearing from the guys. I'm worrying about you ladies here. Yeah. Come on, ladies. All right. Okay, I'm glad you're here. It's hard to know. I'm all by myself here with my dog. All right. Okay. The next medication we're going to talk about, um, who cares if you're wrong? It doesn't matter. All right. The next medication we're going to talk about is spironolactone. So this medication, the shame. That's pretty funny. This medication works in a different part of the nephron. This is working in the distal convoluted tubule. And this medication has some similarities with the medications that change the renin-angiotensin-aldosterone system, because spironolactone is an aldosterone inhibitor. So the other medications were manipulating electrolytes in the nephron to try to get rid of water. This medication is blocking aldosterone. So we have to remember what aldosterone is and what its usual job is, which means we have to go back to the renin-angiotensin-aldosterone system. So the usual job of aldosterone is to save water and sodium and get rid of potassium, because the whole system started because there's decreased blood flow, decreased blood pressure sensed by the kidney. And so renin is released by the kidney, which converts angiotensinogen to angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme. Angiotensin 2 fits onto receptors on blood vessels, which constricts the blood vessel, and angiotensin 2 also activates the adrenal glands to create aldosterone, and aldosterone saves water and sodium and gets rid of potassium, because the whole goal is to increase blood pressure by increasing peripheral vascular resistance and increasing fluid volume. So if I block aldosterone, I will get rid of water and sodium and save potassium. I will do the opposite. So the reason to give spironolactone is to get rid of fluid without having the hypokalemia. And so usually that's how it works, where I get rid of fluid without having the profound decrease in potassium. However, for some people, it could actually cause potassium to get too high. So just like lisinopril, losartan, and aliskiren, we had to worry about hyperkalemia. We have to worry about hyperkalemia potentially with spironolactone. The other issue is that it is close in its chemical structure to some of the sex hormones that we create in our body. So it's similar to progesterone and testosterone. So if you're a man and have an increase in progesterone, it might cause breast development, it might cause some secondary sex characteristics common to women. Common to women. For women, if there's an increase in testosterone, there might be a change in the voice or facial hair or things like that. So it'll change secondary sex characteristics in women, and it can't be used in pregnancy. So those are the main medications that we use in terms of diuretics. The next medication we're going to talk about, the last medication we're going to talk about for heart failure, is digoxin, which is called a cardiac glycoside or a positive inotrope, meaning its whole job is supposed to increase the strength of contraction of the heart. So it does that by changing the way calcium moves into heart cells because calcium helps promote muscle contraction. It also slows down the heart rate usually so that you have more time to fill the heart appropriately and generate action potential. So that's its main mechanism of action is increasing the efficiency and strength of contraction. So digoxin is a very effective medication for treating heart failure, which means the patient will have decreased symptoms of fluid being in places it shouldn't be. However, it has a narrow safety margin or a narrow therapeutic range. And so this is one of the therapeutic ranges that people have to memorize. So people who are on digoxin have to have their blood checked regularly to see that it's in the right range, and it should be 0.5 to 2 nanograms per milliliter. So that's not a very large amount. If it's less than that, it's likely that the patient still has symptoms of heart failure because that's not high enough. If it's greater than that, the patient has risk of digoxin toxicity, which is an emergency. So this is a very tiny range, and if the patient has a blood test for their digoxin level and it comes back as 1.9 or 2, you are allowed to get it. Are we those people? Yes, Ryan, you are those people. Memorize it. Yes, that's awesome. What do you say? People need to memorize? Yes, you are those people. Yes. Because sometimes there'll be a question on the exam that I'll say, okay, patient had their blood tested, their digoxin level is 1.9. Will you give the medication? So you would have to know what the range is. And sometimes, oh, well, yeah, I mean, people who are on the medication should know that too, but for the exam, you have to know it. So that'll sometimes happen, and people will get the answer wrong, even though they know that the range, they've memorized the range as 0.5 to 2 nanograms per milliliter. When they see that the blood test shows that the patient's level is 1.9 to 2, they will incorrectly say the patient should hold the medication only because it's on the upper range of normal. And people sometimes think, oh, you're trying to trick me. I'm supposed to know the range, but you're going to say, well, that's too high, and I have to be careful. That is not correct. This is a tiny therapeutic range. So if the patient's level is 2, they should take the medicine. So don't walk yourself down that road so that you get something wrong when you actually know what the therapeutic range is. The other issue is that digoxin, there's an increased risk of toxicity if the potassium level is low. It's not that digoxin causes hypokalemia. It just means that if the potassium is low, it changes the way the body metabolizes the medication, and there's an increased risk of toxicity. So frequently, people on digoxin are also taking furosemide, which decreases potassium, so that further increases the importance of them maintaining a healthy potassium level because it could increase the risk of toxicity. So this toxicity symptoms is always on the exam, especially being sure that you note the early signs and symptoms of toxicity are rather vague and are similar to side effects in other medications. So usually if the medication causes nausea, vomiting, and anorexia, meaning decreased appetite, we're like, oh yeah, most medications cause that. It's not a big deal. For digoxin, it is a big deal. It is the earliest sign of toxicity. So if someone's taking digoxin and they call the office saying that they feel like their stomach is upset and they have a decreased appetite, your answer is not, oh, that's normal, medications usually do that. Your answer is, okay, come in and we'll check a digoxin level because you know that's early sign of toxicity. The next sign is changes in neurofunctioning. So it can be headaches, it can be vision changes, it could be changes in hearing too. So that's why I put with Digoxin, just a little trivia, I always put a picture that was painted by Vincent van Gogh because it usually makes people see yellow halos. And in the past, Digoxin was used for management of mood. And so people think sometimes that Vincent van Gogh painted things with yellow halos and painted with yellow a lot because he saw yellow because he was taking Digoxin. It's a little trivia for you. The other issue is, and what we were trying to avoid, the dangerous toxicity is dangerous heart dysrhythmias, that especially heart blocks that could cause problems for the patient, lead to hospitalization or potential death. So if the patient is toxic on Digoxin, there is a reversal agent, which is almost like an antibody. It's IV Digoxin Immune Fab. And what its brand name is Digibind, and it's reversing or binding the excess Digoxin to protect the patient. So that's an important slide. It will definitely be on the exam. It's an oral medication or an IV medication. Oral Digoxin you can give with food and you can crush it, which is not always the case for medications. A lot of medications you aren't allowed to crush. And if you're giving it IV, you have to give it slowly, over 5 minutes. And it is a vesicant, meaning that if the IV is not in the vein correctly, and this medication gets into the tissue around the vein instead of in the bloodstream, then the patient could get skin damage or burns to the skin. So you have to be sure you have a working IV before you would give it by flushing, etc. So that is the main medications for heart failure. Antihypertensives, we know we've already talked about those last class. In general, lisinopril is the top choice. Diuretics, in general, furosemide is the top choice. And then for contractility, it's Digoxin. There are emergency medications that are given IV short term for people with an acute exacerbation of congestive heart failure. These are dobutamine is an example, and milrinone is an example. These are medications that are given continuously IV, which require ICU monitoring. This is just information for your information. These two drugs will not be on the exam. They are on ATI, however, so you do have to be aware of them. Okay, so now it is 10:30. So for the next half hour, so this would include a break too. This sheet here says congestive heart failure medications. Think about side and adverse effects of congestive heart failure medications and make yourself some kind of study sheet from this. And then take that study sheet and upload it to the congestive heart failure, which I just opened here, congestive heart failure medication side and adverse effects. And we can see how well you're getting those together and how as a way that might help people study. So here's the sheet, congestive heart failure side and medication effects. This is where you would upload your example of a study sheet that you're making. I'll show you mine when we come back from break. So work on that and get something to drink, go to the bathroom, whatever, and we'll restart again at 11 o'clock.